Thank you once again for the invitation, and we'll talk about dialysis access cannulation. So it's kind of interesting that many a times, many people, at least in our programs, might graduate to become nephrologists and continue to practice, but they have never placed a single dialysis needle into a fistula. Somehow this has completely gone out of nephrologist's hand into the dialysis nurse's hands. So just a few brief things about the cannulation. Is probably one of the next critical step. Even though you may have gotten a beautiful fistula created, well matured, with all the devices and techniques that we have, and if you have a bad cannulator, they can actually mess it up completely. So cannulation is as important as getting a good mature fistula, especially in the new fistulas. With all the fistula first policies that we are doing, and we're trying to create all the fistulas, and many times these are not optimal fistulas, and they probably need a little bit more care and tender love. And when you're cannulating the needles or the fistulas, you really need to be careful. What is interesting is if you look at the literature, there's only less than 10% of new fistulas can be successfully cannulated with 2 needles with no complications. That means a missed cannulation or miscannulations are highly prevalent, especially in the beginning when you're doing it for the first 2 to 3 weeks of a new fistula. Infiltration rates could be as high as is very high, and especially among the new fistulas for the first 6 months, to be honest with you. So the status of the cannulations has not changed in a very long time. It continues to be feel and stick approach. Cannulators are generally trained on the job, and these days we are now having some phantoms to train them, but most of the time the phantoms were the patients to begin with. So in our dialysis units, now we have created what is called as an expert cannulation team who will be assigned only to do the cannulations of brand new fistulas to avoid this kind of a problem. To be honest with you, if you keep looking for the literature on the complications, it's not there. Very limited literature has been published. And 1 in 2 patients will have miscannulation the first 3 dialysis sessions. So that first 1 to 2 weeks is extremely critical, and you need to pay close attention if you really don't want a messed up fistulas. And definitely the fistulas are more common to have a problem than the graft, and if you have a miscannulation in a graft, then we have a problem. Either the graft was not placed superficial enough, or the cannulator should be looking for another job. The upper arms generally have a lot more problems with cannulations than the lower arm. So many societies have actually come out with some recommendations on various aspects of cannulations. That would be your needle size, what size needle you want to use for what blood flow, the angle of needle insertion that has been talked about a lot, and especially in the workshop we went over this in detail with our dialysis nurses and techs. The direction of the needle bevel that has been already talked about. It needs to be bevel up, and don't rotate it after you put it in. And the amount of pressure that you apply on the fistula at the time the needle is pushed in is also important, because you really don't want to kind of back puncture things. So among the types of the cannulations, there are different types. The most common one, or the highly prevalent one, is the rope ladder or the side rotation. But what you actually get is an area cannulation on one side, is where there's only a small segment of the fistula is cannulated multiple times, and it weakens the wall, causes the aneurysm, which is also probably a complication of the cannulation techniques. The other one is the buttonhole method, which we'll go over. It has its own set of pros and cons about using that. So the buttonhole cannulation is, it is a buttonhole. You put a small, you keep on putting the needle into the same hole repeatedly at the same angle, and at the same, and preferably by the same cannulator, so that you can control the angle and the insertion technique. So it takes about 3 to 5 cannulations, or 3 to 5 dialysis sessions. And what happens is, because the needle has gone through the same thing, that track starts to become fibrosed. Now, there is going to be a fistula to the skin. Well, it cannot be called another fistula, but it's a endovascular to skin cutaneous fistula that you're creating, right? So, and every time you take out the needle, the blood kind of comes back into the tract, forms a platelet plug, and it kind of seals it up. This is not something new. This was actually in 1978 was the first time it was reported by Dr. Twardarski. Basically, it was actually incidentally developed by a patient who was having a very short cannulation segment. So he tried to keep doing the same thing, and subsequently many people started to use this technique in patients who had limited cannulation segment where you couldn't do the rope ladder methodology. So after the first 3 to 5 cannulations, you generally switch from a sharp needle that you have that you normally use to a blunt needle, so that you don't traumatize this tract, because every time you traumatize the tract, it heals up with more scars, and you might actually lose the entire tract after that. The orientation of the needle is generally in the direction of the blood, because that way, when you take out the needle, the bleeding is less. When this cannulation methodology was talked about in the early days, everybody picked it up, and mainly because there was a lot of observations saying, oh, there is less pain because you're creating a tract, it keeps going in and out, so they shouldn't be feeling much pain. The patient loved it because they thought that you're putting it in the same spot, so there is less scarring, and that bumps that was happening was less, which is true. With the buttonhole, you do get less aneurysms, and people were, or at least the presumption was, they were clotting off much quicker. Once it was being evaluated in randomized controlled trials, that's when you started to appreciate the more and more infections happening, because when the tract closes at the skin level, there is a scab which forms, and how you remove the scab makes a huge lot of difference. If you are using a sharp needle to pick the scab, or if the patient picks with his finger, you know what's going to happen. An infection. So the infection risk has been a real one with the buttonhole, and despite of having some mixed or heterogeneous studies, when you pull the results together, you're still getting the infection as a major risk. Agreed that there is a small sample size in most of these studies, but it's still a problem. So what is the optimal cannulation method? The evidence at this point in time is kind of inconsistent. There was a point in time where everybody wanted to do the buttonhole, but the infection risk pretty much scared everybody away. So now the rope ladder method continues to be the most prevalent used if you have enough cannulations length, especially if you have at least 10 centimeters. And in the patients with limited cannulation segment, or in the patients who have self-cannulation, buttonhole is probably the best. And the biggest barrier for optimal vascular use is actually inconsistent nurse cannulation. So standardizing your cannulation protocols in your dialysis units is extremely critical to have a successful vascular access program. Now, cannulation and outcome, does it make a difference which cannulation method you use? There was a very big study which was reported from the Europe, which showed that among all the cannulation methods, they also looked at the needle size. If you're using 17-gauge needles, the access doesn't do as well as when you're using 15 or 15-gauge needles. And the same goes with your venous pressures, but I really want to highlight this cannulation techniques, which is the buttonhole, rope ladder. It doesn't really matter because neither of them are influencing the access survivability. But another important finding which came out of this is actually the tourniquet use. When you're applying the tourniquet, comparing that with the patient assistance, when the patient puts a finger and occludes the fistula, tourniquet use had a higher risk of complications, which is kind of interesting, which needs to be looked into, and as it's going to affect our practice patterns. Now, coming to the plastic needle, and this is a recent randomized control trial which looked at our metallic needle versus a plastic cannula, which has a 4 small holes and the inner needle. So you enter the fistula and then pull the needle out and let the cannula in. It was a pilot study. We wanted to look at the development of aneurysms and stenotic lesions in 1 year. Most of the infiltrations happened with the metallic needle and generally 2 hours into the dialysis, so that suggesting that mainly due to the patient movement, hand movement. And the plastic needles did better because they can be a little bit more amenable in that regard, but it was not a convincing one. Again, it is a pilot project. It needs to be looked in a larger setting. As far as self-cannulation, with the home hemodialysis taking the center stage, the self-cannulations is an important practice that needs to be standardized. Most of them, they use the buttonhole. Patients do feel very empowered when they can actually cannulate themselves. So even in-center patients, when you allow them, given an option to do the self-cannulation, and if they're motivated, they are actually more compliant in this regard. So a self-cannulation should be promoted, and it helps to improve the outcomes. With that, as I said, the rope ladder continues to be prevalent. Infection is a problem with the buttonhole, and self-cannulation should be promoted. At that, I'll stop and take any questions.